So our next presentation is by the group at Duke. Neel Prabhu is going to be talking about ductal stenting and systemic to pulmonary shunts.
Good afternoon, everyone. First, I'd like to thank the Society again, as well as the moderators here for allowing me to present my work. I'm excited to discuss the role of ductal stents and surgical shunts in the treatment of single ventricle patients. We have no relevant financial disclosures. Since the pioneering work of Blaylock, Taussig, and Thomas in the 1940s, the systemic to pulmonary shunt has really been the mainstay palliative treatment for cyanotic newborns born with duct-dependent pulmonary blood flow. However, there have been reports in the literature of high rates of morbidity and mortality associated with this technique. And furthermore, single ventricle patients are at higher risk, as a well-developed and unobstructed pulmonary artery system is critical to single ventricle palliation. Furthermore, we've observed that single ventricle patients tend to be more vulnerable in the interstage due to the lack of two well-developed pumping chambers. Ductal stenting has been an emerging alternative, but data regarding its palliative efficacy is quite mixed, and data on single ventricle patients specifically is quite limited. At our institution, we historically struggled with poor outcomes with surgical shunts in single ventricle patients. This prompted us, beginning at about 2015, to transition to the use of ductal stents as our primary approach in this patient population when feasible. And the objective of this study was to highlight our changing practice by analyzing outcomes after ductal stent or surgical shunt placement in single ventricle patients with duct-dependent pulmonary blood flow. We included all functionally univentricular patients in our analysis, treated at our one center from 2015 to 2019. Shunts were placed via standard median sternotomy, and ductal stents were placed via femoral or alternative access if ductal anatomy was tortuous. Our primary outcome was survival to next stage surgical palliation, and our secondary outcomes included duration of mechanical ventilation, the need for ECMO, interstage reinterventions, as well as procedural success, which was defined as retainment of the initial shunt or stent until the next stage surgery. The diagram on the right here shows our cohort selection process using an intention to treat analysis as previously performed, where any instrumentation of the duct was considered part of the ductal stenting group. We had, over a 5-year study period, 11 single ventricle patients that underwent ductal stent placement, and an additional 23 patients that underwent surgical shunt placement. Our results first show no baseline differences between the groups in terms of age at operation, gestational age, weight, and preoperative oxygen saturation. Furthermore, there were no differences in the underlying distribution of anatomic diagnoses, with pulmonary atresia and intact ventricular septum, as well as unbalanced canal, being the most prevalent diagnoses. There was no difference in procedural success between groups. One ductal stent patient developed ductal vasospasm during the procedure and required ECMO cannulation followed by the placement of a surgical shunt. And an additional ductal stent patient initially had a successful procedure, but was found to have LPA obstruction 4 days after the procedure and was converted to a surgical shunt. A total of 4 surgical shunt patients required open shunt revision during the index hospitalization, and all of these were due to shunt thrombosis, and that represent the 4 failures in the surgical shunt group. Here's some further procedural characteristics. Of note, I'd like to highlight that nearly half of our shunt patients received pulmonary arterioplasty at the time of their initial operation. Our ductal stent patients fortunately did quite well, with 100% survival to discharge, stage 2 operation, as well as 1 year of life. Conversely, the shunted patients experienced steady attrition with 83% survival to discharge, 64% survival to stage 2, and 61% survival at 1 year. And on the right is a Kaplan-Meier curve showing this survival data. Regarding various measures of in-hospital morbidity, median duration on the ventilator was shorter in the stent group, And there were trends towards decreased need for ECMO post-procedure, as well as ICU length of stay, but these did not reach significance in our analysis. An important topic when analyzing outcomes after these two interventions is need for interstage reinterventions. And we found in our analysis no difference in the need for interstage reinterventions. On the right is a Kaplan-Meier curve showing freedom from reintervention with either the stage 2 operation or interstage death treated as competing events. Upon further stratification, we found there was no difference in the frequency of unplanned reinterventions for cyanosis, nor planned reinterventions between the groups in the interstage. And lastly, there was no difference between the groups in the time from their initial palliation to the Glenn operation. There was also no difference in the proportion of patients requiring pulmonary artery reconstruction work at the time of their Glenn operation in our cohort. We acknowledge the various limitations in our study. For instance, this was a retrospective single-center study with relatively small sample sizes. However, single ventricle heart defects with duct-dependent pulmonary blood flow are rather rare. And in addition, it's possible that the groups may not have been balanced at baseline, given that nearly half of our surgical shunt patients received pulmonary arterioplasty at their initial operation, which may suggest higher baseline risk in that cohort with more complex PA anatomy. In conclusion, there is really no current consensus in the field regarding the role of ductal stenting in single ventricle patients with duct-dependent pulmonary blood flow. But in our small single-center study, ductal stenting was quite effective. Patients receiving stents had decreased interstage mortality as well as decreased in-hospital morbidity by some measures. And transition to ductal stenting appeared to be highly successful at our center. And one of our motivations for sharing this data with this group is that this experience may be relevant to other centers, especially ones like ours that have historically experienced relatively poor outcomes with surgical shunts in the single ventricle high-risk population. Here are my references. I hope this presentation has been informative. I'd like to take the time again to thank the Society for inviting me, as well as acknowledge the excellent guidance from my mentors, Dr. Joseph Turek, as well as Dr. Nick Anderson. I'm happy to take questions at this time.
Well, congratulations on a great presentation, Neel. So I want to remind everyone that he's a third-year medical student. So while we wait for people to come up, so it looks like there's a 40% chance of going on ECMO after a shunt. Is that correct?
In our analysis, that's correct.
So do you think, I mean, I think your point of having, of whether these patients are actually the same or not is actually a pretty important one. So how do you, at your institution, select whether a patient gets a PDA stent or a shunt, I mean, during the group? And I don't know if Joe wants to answer that, or, I mean, this comes from 2015 till now, is that right?
Yeah, for this answer for clinical management, I think I'll defer to my mentor, Dr. Turek.
Yes, yeah, so this cohort is from 2015 to 2019, both the surgical shunts as well as the ductal stents. I will say that this is much more biased towards the ductal stents being 2017 to 2019. We actually 3D print all of these hearts ahead of time when we're trying to decide. We're looking for not only what's the tortuosity of the duct, but some idea of what's the best approach. Is a carotid cut down better than a femoral approach for this? And then also kind of looking to see what the, if the PAs are rising from the duct, the LPAs are rising from the duct, and in those cases, we would probably do a shunt as opposed to a ductal stent.
Do you guys have any incidents of LPA isolation or LPA problems?
Yeah, we have had some of that in the past, and I think that's probably I'm a little surprised that we don't have higher PA reconstruction on these patients, because just in my thought it just does seem to be more common that we have to go and patch the PAs afterwards after we've done this.
Have you extrapolated this set of data to other conditions now for stenting?
We basically use, this is the single ventricle series, but we use it, our primary modality is to stent ducts if we can, and if it's not amenable to a stent, then we'll do a surgical shunt. But I got to say, I mean, the number of surgical shunts that we've done over the last 3 years is pretty minimal.
Interesting.
Neel, first of all, congratulations. You speak remarkably, for your the stage of career where you are. It's a very good presentation. So congratulations on that. But like you mentioned in the limitation that you acknowledged in the limitation, really the elephant in the room really is that last limitation that you mentioned, right? Because surgical are generally poor risk patients, especially the cath lab feels uncomfortable, then they'll defer it to the surgeons. So my question is, why did the patients end on ECMO? Was it because of the increased use of blood products that was related to bleeding after shunt, or was it, usually that is the scenario where the Gotex graft bleeds because of hemodilution, on small babies. You end up giving a lot of blood products, and then the function of the heart and the lungs goes down. So do you know the exact reasons why 40% of patients ended up on ECMO?
Yeah, that's a good question. If I'm understanding correctly, you're asking the indications for ECMO within the cohort. So really it was a high instance of hemodynamic instability in the patients receiving the stent group. I think that it's just a combination of the relatively short shunt size we use, as well as the location that just results in increased diastolic runoff and coronary steal. We actually had a relatively high incidence. I didn't report this in the presentation of post-procedure arrest in this cohort. And that was the instability. It was kind of the main indication for ECMO.
If the patients went on ECMO, how did you manage the shunt? Did you go back and revise the shunt, or did you just clip the shunt in that time?
So a fraction of the patients that received ECMO were able to be decannulated without further surgical intervention. But there was a fraction that, after they were placed on ECMO, were taken back to the operating room and underwent a shunt revision.
The reason I bring this up is, if you put a single ventricle patient who has had a shunt on ECMO, you need to control the pulmonary blood flow, right? So it may be possible that clamping the shunt may be the results why you're having poor interstate survival too, right? One of the ways we have dealt at NYU is I've been using non-valved segments of saphenous veins. I have to tell you that it's like day and night. Using PTFE grafts on small babies was using these biological grafts. They can be easily dilated, like 3 to 4 months later if they undergo some sort of narrowing. You virtually don't need to use any blood products at all. It's something I'm just putting in your mind that that may be the material to go for neonates.
Yeah, that's absolutely a great point. I think one of the items that came up in our discussion was, again, one of the things I mentioned is the high incidence of PA-plasty in this cohort. And we think that the high incidence of shunt thrombosis we had in the shunt group was likely due to the apposition of 2 prothrombotic surfaces, right? You have the PA-plasty being done with a patch, and you have shunt being placed on top of that. Interestingly, in a lot of the similar analysis in the field, especially analyses by Meadows et al., a multi-center study, single ventricle looking at ductal stent, surgical shunt, they actually exclude patients that underwent any concomitant surgical procedures at the time of their shunt placement in their analysis. So that was actually the practice, the conservative practice of the surgeons at the time in our cohort to go ahead and do PA-plasty, whereas other centers, maybe regional differences, where other centers tend to do more PA reconstruction work at the time of the Glenn operations. Another factor to consider.
So we are pretty aggressive too with PA-plasty, except that I use the same saphenous wall. I just fill it open and I use it as a PA material. It works out very well.
I see. Thank you for your comments.
Yeah.
Mine is just a comment. First of all, congratulations on a very nice presentation. We've also moved to stenting, the ductus and single and, biventricular patients. One thing that I wanted to sort of echo what Joe was saying in terms of the preoperative assessment of these patients. I think that it's a brilliant solution. I think that these patients tolerate, a relatively sizable shunt much better than a BT shunt. They actually, maintain hemodynamics much better in the face of overcirculation. They're short sometimes, they're, larger shunts, and they actually do well postoperatively. It's a little bit of a pay me now or pay me later in terms of PA-plasty afterwards, much more, with these patients. But, we actually have been using carotid cut downs for these patients. And the last one, which was almost one of my worst nightmare cases, there was a dissection and a complete occlusion of the LPA at the time of the deployment of the stent. So the one thing that I've learned from that is that once you're there with a carotid cut down, the carotid is open, you got a sheath in there, our colleagues from interventional cardiology have a very low threshold to say, well, yeah, it's a little bit tortuous, but let's just deploy a stent. So I think that the most important thing for these patients, once you decide to go that route, is preoperative imaging with 3D reconstruction. Just not to be in that kind of situation.
Yeah, I think that's a very good point.
All right, thank you very much.
Okay, thank you very much.